This chapter will cover the following allergic conditions: allergic rhinitis, insect venom allergy, food reactions, urticaria and angioedema, anaphylaxis, atopic dermatitis, contact dermatitis. In addition, we will talk about asthma. The most common form of allergy in children is allergic rhinitis or allergic rhinoconjunctivitis. There's an increased risk of this with early introduction of formula or solids and maternal smoking, particularly before 1 year of age. The way to make the diagnosis from a historical standpoint is to find typical symptoms of allergy in the absence of obvious repeated upper respiratory infections or structural abnormalities, for instance, a deviated septum. The common findings include nasal congestion and pruritus, which is worse at night with a postnasal drip and often a cough. There may be loud snoring with chronic allergies because of adenoidal hypertrophy, mouth breathing, and then watery, itchy eyes. Specifically, the patient and the family are usually able to tell you that these findings occur in the presence of one or more allergens, particularly in the spring and in the fall because of pollen production. On physical examination, we may find specific behaviors. The child may be rubbing his nose upward because of pruritus, which is known as the allergic salute. May be grinding his eyes with his thumb and the side of the fist, again because of pruritus. We will look at further physical findings. It is important to question regarding a family history of atopy, that is, people in the family with obvious allergies, asthma, or atopic dermatitis. On physical exam, we may find allergic shiners, which are dark areas under the eyes. This is due to venous stasis, and if this is chronic, you may even see individual lines within those dark areas, and these are called Denny lines or Denny-Morgan lines. The conjunctiva of the eyes during periods of acute allergic attack have chemosis or injection, and what is called cobblestoning of the tarsal or palpebral conjunctiva. Over time, because of the rubbing up and down of the nose, that is what we call the allergic salute, we may actually have a transverse nasal crease between the soft and the hard tissue of the nose. If we look in the nose, we can see a pale nasal mucosa with hypertrophied turbinates, which obviously lead to obstruction of airflow. They often have repeated otitis media with persistent effusion, and over time, with chronic effusions, this may lead to conductive hearing loss. In the presence of obvious findings without upper respiratory infection or anatomical abnormalities, particularly again with a good strong history of allergic exposures bringing on the findings, there really isn't much of a differential diagnosis to think of. However, if the diagnosis is in question for whatever reason, here's a short list of findings that might also be compatible with similar findings. Vasomotor rhinitis, which occurs because of a number of physical stimuli in the absence of obvious allergic etiologies. Children at times may have nasal polyps for one reason or another. The most common is cystic fibrosis. Nasal polyps in children should never be considered to be normal. They may produce, again, symptoms of nasal obstruction and findings very similar to those found in children with allergies. The major anatomical problem, again, to concern yourself with in terms of a differential diagnosis is septal deviation, overuse of topical vasoconstrictors, which are over-the-counter preparations that are used for congestion, typically with a common cold, or even with chronic allergies, can lead to rebound congestion, and it's often very difficult to get off of these medications. And rarely the condition of Wegener's granulomatosis, which, while we should think of it as certainly the last on the list, the diagnosis of exclusion, and very uncommon in children. The American Academy of Pediatrics has recently put out a statement that the diagnosis of allergy in children should be done entirely by clinical methods, that is, history and physical, based on the things that we just said. There is no routine test that we can do that is always positive in children with allergy, and in fact they may be negative. Things like finding peripheral eosinophilia or an increase in serum IgE may certainly be positive, and if they are helpful. However, if they're negative, in the presence of obvious history and physical findings suggestive of allergy, you're certainly not going to say then that it's not allergy because we don't have these two findings. In addition to that, those findings, peripheral eosinophilia and an increase in IgE, may become positive over time. Perhaps it takes more than one season of allergic exposure. Perhaps it's a year or 2 years until ultimately the patients have an increased response. However, those who are less atopic relatively compared to others who are more atopic may not have at all an increase in IgE or peripheral eosinophilia. On the other hand, if the child comes in with obvious findings at the time of an allergic attack, then if we do a simple nasal swab and put it on the slide and stain it, we usually should be able to see eosinophils. But again, in the absence of an acute attack, this certainly may not be present. The way that this is helpful is because it pretty much confirms that those symptoms that are going on at the time are allergic. If, on the other hand, you did a nasal swab and you found a number of neutrophils primarily, then obviously that would not go along with allergic rhinitis. That might go along with chronic infection, like we may see rarely in children with chronic sinusitis. Now, the best test is the in vivo skin test, as you can see in this picture. This requires, however, getting a good history of the most likely allergens in this child's environment that may be causing the allergic responses. We, as usual, again, start with a history to try and figure out the best that we can what the allergens are. This can only take us so far, typically. Many times people are unable to identify the exact allergen. Sometimes it's relatively easy. And so we can find that then based on skin tests. We aren't going to start the workup, however, with skin tests. After the history and physical, then the next step in management is of empiric therapy, and of course doing the best thing overall for any form of allergy, which is trying the best that we can to eliminate the allergen based on the history and the environmental history. Once again, we may be able to do this, we may not be able to do this. We may be able to eliminate some allergens, but not necessarily all. So the rule in terms of referring to an allergist to do the best testing, which is again the skin test to find the allergens, is the continuation of allergic response to such a degree over at least 2 or 3 seasons that it is affecting the life of the child, typically on a daily basis, in the presence of maximal medical therapy. That means at this point we've gone as far as we can in terms of empiric therapy, and we have gone as far as we can in terms of avoiding the allergen, and now we have to find out exactly what the allergens are. So as I said, the overall most effective method of empiric therapy is environmental control plus removal of allergens to the extent possible. What do we mean by environmental control? Well, this is getting rid of the most obvious allergens in the child's environment, outside and inside. Now, outside it's a little harder to do. There are so many types of grasses, trees, plants, weeds, etc. that cause the problem that we just can't start ripping everything up, and they are present in many, many places beyond the child's of the house and outside where the child typically plays and goes to school. So again, this is limited. However, within the house, there are certainly a lot of things that we can do. We can remove cats, which are highly allergenic. We can clean the place up with respect to dust and dust mites. And we can remove the most highly allergenic materials, particularly in the child's bedroom. The empiric therapy first involves pharmacological therapy, and the first line, the best initial drug, is one of the second-generation antihistamines, primarily cetirizine, fexofenadine, or loratadine. They have significantly less cholinergic effect and are non-sedating. We now know that oral antihistamines are more effective than cromolyn, but less effective than the best drug, which is intranasal steroids. And they have synergy with intranasal steroids as well. So we typically don't use cromolyn routinely anymore, but nasal cromolyn prophylactically, of course, because it is a mast cell inhibitor and has to be given for a period of time and on a regular basis before it has an effect, is typically given intranasally when there are allergens which simply cannot be removed and avoided. Once you follow the child on the second generation antihistamines for a while to see how they're doing, again with environmental control and allergen removal to the extent possible, if the follow-up shows that the patient has had perhaps some response but not a significant response, then the next step in management is to add the intranasal corticosteroids. Again, they are most effective, but they aren't the first line, they're an add-on because it is a steroid, and being that it is a steroid, even though it's topical, it certainly has an increase in side effects compared to the oral second-generation antihistamines. The best long-term therapy is immunotherapy, desensitization, or what lay people refer to as allergy shots. They are used when the duration and severity of symptoms are disabling in spite of routine treatment. Now, before we start immunotherapy, of course, the most specific, the best test needs to be done, which is skin testing by an allergist to determine the allergens that should go into the makeup of the allergy shots. These are then ordered through a laboratory who make up the vials of the immunotherapy allergens, which are then injected into the child in very, very slow, increasing concentrations over time until it's built up to a maximum. And then there's a long period, typically of monthly maintenance shots, which can go on for 3, 5, or more years. The reason that we often hear from people that they had allergy shots and they weren't effective is because they tend to give up. They don't go on long enough for them, and it can be very costly, and if an insurer is not going to pay for them, then it becomes a problem. However, we do know when they are given correctly and over a long period of time that for the long duration of a person with respiratory allergies particularly, that is until later childhood, adolescence, and adulthood, they are highly effective in the control of symptoms. Allergy shots, desensitization, immunotherapy should not be used. That is, we do not have evidence that they are effective in atopic dermatitis, food allergy, latex allergy, urticaria, and very young children under 3 years of age. Children with ongoing allergic rhinitis that is poorly controlled are at risk for chronic sinusitis. Again, this is relatively uncommon. They may have concomitant asthma. 80% of children with asthma have true atopic asthma. Because of physical findings, because of pathology within the nasopharynx, the throat, there can be chronic swelling and abnormal function of the eustachian tube causing chronic obstruction. All of this can lead to tonsil adenoidal hypertrophy, which can lead to further obstruction. And the most severe symptoms, again, over time can certainly lead to emotional problems and psychological problems if the findings are severe enough and not well controlled that they are chronically interfering with the daily activities of the child and, in fact, the rest of the family. Insect venom allergies in children can cause very severe reactions and may be the initial presentation to the emergency room of a child with anaphylaxis. These are allergic responses that are IgE mediated, mostly due from things of the order Hymenoptera. But in general, bees, honeybees, bumblebees, wasps, hornets, and even red fire ants are the groups of stinging insects that we are concerned about. Now, most people, children included, who are stung by one of these insects, typically have a local response, some swelling and induration, erythema and pain of hours to less than a day's duration. However, a significant allergic response to these will be systemic findings, that is, urticaria, angioedema, and the worst, anaphylaxis, which of course may be associated with breathing problems and cardiovascular problems, particular hypotension. We can even see some delayed responses like serum sickness and rarely vasculitis. So because it is very difficult for a child to avoid stinging insects, or for anybody for that matter, you just can't keep running away from things that you see flying in the air. If you have had a severe allergic response and you're stung again, this can lead very quickly to anaphylaxis and even death. And so it is the standard of care then that when we have diagnosed a systemic insect venom allergy in children, we must pursue the diagnosis of which insects are causing the problem. And this means either skin testing if the allergist feels that it is safe to do, because again, if this is a presentation after anaphylaxis, then putting the allergen into the skin may again provoke an anaphylactic response. Or if the allergist does not feel that this is safe to do, then blood can be drawn for IgE-specific allergens to determine again which are the problematic stinging insects. For any insect sting, the immediate local treatment should be cold compresses, topical antipyretic, oral analgesics, and attempting to remove the stingers by careful scraping. If there's an anaphylactic response, systemic response, hopefully the child will have been taken to the emergency room for immediate treatment. And once anaphylaxis due to an insect venom allergy or any significant allergy has been diagnosed, then the child needs to be provided with and fully educated with, including the family, of course, an epinephrine pen. But this then is an absolute indication for immunotherapy, that is, allergy shots with respect to insect venoms. And this, of course, is the reason why we have to do the diagnostic testing to determine which of the insects are problematic, so that the ones where you do have significant allergies can be used to be put into the allergy shots for years worth of desensitization, so that this can get controlled, hopefully early in childhood, and the rest of the person's life is not going to be problematic in case they get stung again. Now, food reactions are the most common cause of anaphylaxis seen in emergency rooms, and after this, drugs, and after that, stinging insects. The difference of food reactions, food allergies, which are relatively common in children, particularly young children, is that they can be mediated by either an IgE and or a cell-mediated response. It is extremely unusual, in children at least, to have pure respiratory findings with food reactions. Usually we have a combination of skin and GI, and less commonly cardiovascular and perhaps respiratory findings. The classic findings with respect to the skin for an acute response are urticaria and angioedema, and there's a strong relationship then to children who have atopic dermatitis and specific food allergens as well. The GI findings are diarrhea, vomiting, abdominal pain, sometimes blood in the stool, and if this is occurring chronically because the food or food groups to which the child is allergic are continuing to be introduced, then there can even be weight loss and failure to thrive. Again, don't forget that this can be a cell-mediated response. It doesn't have to be. It can be an IgE-mediated response, and again, the food protein may induce a serious enterocolitis so that you might even see bloody diarrhea. In the worst cases, then, we might see the combination of respiratory cardiovascular findings, so that, just like we've been talking about, this can manifest with serious systemic findings, meaning anaphylaxis. The way to make the diagnosis is an elimination and re-challenge because of the issue of it being both IgE and or cell-mediated immune response. And that means that the best test is not going to be looking for IgE allergens, either in the blood or by doing skin tests. If they are positive, well, that's fine, but if they're negative, you haven't gotten anywhere. So that means when you feel that a child has one or more food reactions, food allergies, they need to be sent to an allergist who has the expertise of doing this type of thing. And the allergist then will stop the food or foods in question for some period of time, and then under office conditions where serious reactions can be treated, the patient can be re-challenged with the food. And if allergic manifestations then go away with elimination and reappear with the challenge, then of course that's the absolute diagnosis for that particular food that you're testing. The therapy then is simply elimination. And again, if there have been any systemic responses, particularly anaphylaxis, the child and the family always need to be provided with and instructed in the use of an epinephrine pen. The most common etiologies of urticaria and angioedema follow the most common reasons for severe systemic reactions in children, that is anaphylaxis: foods, drugs, and insect sting. This is commonly caused by, again, acute IgE-mediated reactions with activation of mast cells in the skin and due to the systemically absorbed allergen. We also have a non-IgE-mediated form caused most commonly by radiocontrast agents, certain viruses, certain drugs like non-steroidal anti-inflammatories and opiates, which of course in the young children at least should be very uncommon. We have a number of different physical findings causing urticaria, a number of environmental factors such as heat, cold, environmental pollutants, and certain things causing physical contact on the skin. And rarely children may have hereditary angioedema, and in the absence of getting a positive diagnosis with a thorough history and physical and laboratory evaluation, this always has to be thought of, especially if there are more people within the family who have recurrent urticaria and angioedema. And this is due to the C1 esterase inhibitor deficiency. Here we can see examples of urticaria and angioedema. On the right is angioedema, which is either localized or widespread swelling, often with some erythema. And on the left is a classic example of papular erythroderma, papular urticaria. You can see that there are individual raised lesions that are a pinkish color. They don't all have to be grouped as much as you see this, as dense as this. It can be spread out a little bit more. The characteristics are going to be that the child at some point was fine, then had one or more allergic exposures, and then broke out in the rash, which is extremely pruritic. When you press on these lesions, they should blanch, and then the color should come back again, and the diagnosis is generally pretty easy. The other way that urticaria can look is flatter with widespread irregular margins that are called serpiginous margins, snake-like margins that are slightly pink to red with a paler central area. But again, it's just a different way that it looks. The idea is exactly the same. The child was well, there's an allergic exposure, development of urticaria, which is pruritic, and when you press on the lesions, they blanch, and then when you release, the color comes back again. The management for urticaria and angioedema is the obvious avoidance of the trigger as much as possible with the use of oral antihistamines. If severe, the use of epinephrine and even short bursts of corticosteroids. Remember that urticaria is not responsive to allergy shots. So we have to identify the problems, that is the food or foods that are causing this, which again is not responsive to allergy shots, the pharmacological drug that is causing this. At times the drug itself may be managed with desensitization, but the finding of urticaria and angioedema is not. Similarly with respect to what we said about insect stings. So anaphylaxis in children, as in anybody, is due to the sudden release of many active mediators and inflammatory mediators. And out of the hospital, once again, in children, we see the most common etiologies, which are food, drugs, and insect stings. In the hospital, latex and antibiotics account for the vast majority. When you see a child with anaphylaxis, a severe systemic reaction, the treatment is pretty much the same as in any person. The drug of choice immediately as soon as possible is injectable epinephrine. And if the child has already been diagnosed with anaphylaxis in the past, they should have with the family an epinephrine pen, and this needs to be taught to be given as soon as possible, and then get the patient to the emergency room. Other ancillary therapy may be necessary depending on the signs and the symptoms, oxygen, further airway management. But then after this, the next drug is a corticosteroid, and then we typically give one of the older antihistamines such as diphenhydramine. Again, the rest of the treatment is based on symptoms. Another example would be if the patient has severe respiratory symptoms, a short-acting beta agonist may be given by nebulization. Atopic dermatitis is due to an interaction among genetic, environmental, and immunological factors. So we often see this within families. It generally starts in very young age, early infancy, is chronic and recurrent and can be severe. It changes over time, which is something we will talk about, but the basis is acute, intense cutaneous activity. That is, the pathology is such that it leads to very pruritic skin, which causes the patient to scratch and bring out the rash. Most have increased eosinophils and an increased IgE, and most cases are associated with asthma and even other allergies. So we see on this little schematic that there's this interaction between the three major atopic diseases, and that is asthma, atopic dermatitis, and allergic rhinitis. Besides the pruritus, which is the primary finding, the rest of the pathophysiology is the skin of people with atopic dermatitis is very susceptible to drying. That is a very easy transepithelial loss of water, particularly upon application of water to the skin, like swimming or taking a bath or a shower. There are a number of exacerbations, allergies, and physical findings that can make the atopic dermatitis worse. Again, as mentioned previously, in children at least, common exacerbations with foods, various inhalants in the environment, various types of infections, particularly bacterial infections. We have a change in the pattern of the atopic dermatitis over time, from early infancy to adolescence and into adulthood. The earliest manifestation is acute atopic dermatitis, acute eczema, and the finding are erythematous papules with intense pruritus, a serous exudate involving the face and the extensor surfaces of the body, like the elbows and the knees. Because of the pruritus and the serous exudate and the intense scratching and rubbing that occurs in these patients, you'll have breakdown in the superficial areas of the skin with small bleeding, and this leads to dry punctate lesions that overall gives an excoriated appearance by the time that we see the children on examination. This occurs through the early part of childhood and then typically changes to a less acute, called the subacute phase. So smaller areas, not as intense, perhaps less pruritus, but typically the characteristic is scaling papules, and the distribution is much less on the face and the extensor surfaces of the body, but now on the flexor surfaces of the body, such as the antecubital fossa. And then into adolescence and adulthood, for children who have had atopic dermatitis chronically since infancy, the skin changes to the degree that there's a significant amount of thickening, discoloration, certain pathological changes, and we call this lichenification. The most important principle of management is to identify and eliminate the causative factors to the best of our ability. On a daily maintenance basis, cutaneous hydration is the most important step in management. That means that every time water is applied to the skin should be blotted dry, never rubbed, and any one of a number of over-the-counter preparations called emollients should then immediately put on the skin all over to keep the water in. So hydration is the best thing that can be done to decrease the pruritus, the intense cutaneous reactivity, decrease scratching, decrease the appearance of the rash. However, even in the best cases, the rash will appear acutely, and when this happens, topical corticosteroids should be applied directly to the rash. We start typically with low potency steroids and then increase the potency as needed to get control of the rash. However, remember that higher potency, that is fluorinated topical corticosteroids, should not be used on the face or intertriginous areas, and only for short periods of time, because they can cause chronic skin changes. So the goal is to again get control of the rash and then step back down on the topical therapy. Relatively newer, but it's been around for quite some time now, a drug that is very safe and can be used on the face and can be used down to children who are 1 year of age, are the topical immunomodulators, and the drug here is called tacrolimus. The most important long-term complications of atopic dermatitis are secondary bacterial infections, primarily with Staph aureus. This is due to scratching. Recurrent viral skin infections, the most common and most important is Kaposi varicella-form eruption, and even warts and the development of molluscum contagiosum. Atopic dermatitis is due to an interaction among genetic, environmental, and immunological factors. So we often see this within families. It generally starts in very young age, early infancy, is chronic and recurrent and can be severe. It changes over time, which is something we will talk about, but the basis is acute, intense cutaneous activity. That is, the pathology is such that it leads to very pruritic skin, which causes the patient to scratch and bring out the rash. Most have increased eosinophils and an increased IgE, and most cases are associated with asthma and even other allergies. So we see on this little schematic that there's this interaction between the three major atopic diseases, and that is asthma, atopic dermatitis, and allergic rhinitis. 6-year-old boy presents to his physician with end expiratory wheezing scattered throughout the lung fields. He is noted to have nasal flaring, tachypnea, and intercostal retractions. These symptoms are triggered by changes in the weather. He has a family history of asthma and atopic dermatitis. He has never been intubated or admitted to the pediatric intensive care unit. His last hospitalization for asthma was 6 months ago. He takes medication for asthma only when he starts to wheeze. The definition of asthma is twofold. Episodic reversible airflow obstruction, that is at least partially reversible airflow obstruction, with chronic inflammation due to a number of different cellular and biochemical processes. The etiology is complex and typically involves an interaction between genetic and many different environmental factors. For instance, a prominent one is cigarette smoke. Most children with asthma have the onset less than 6 years of age, and we find two main patterns. The smaller number of children, about 20%, who start to have their asthma in the first years of life, primarily wheezing, is due to common viral infections. That is, a child for the first time has a respiratory viral infection and then has the development of typical asthma symptoms. When the viral infection is done, the asthma symptoms tend to go away and stay away until the next viral infection. These children have milder asthma. It tends to go away at some point during school age and is more easily treated, and children lose less school days. However, 80% of children have chronic asthma, which is a topic that is associated with allergic disease. And this is exactly opposite of what I just said for the viral-mediated type. This is more severe, harder to treat, more days of school missed, more likely to go on through childhood, adolescence, and even in adulthood, and again is associated with allergic disease. So in this case, the asthma needs to be treated and the allergic disease needs to be treated as well. The most important clinical presentation, the most common, is diffuse expiratory wheezing. If the child is really sick on presentation, severely ill with limited airflow, then you may hear biphasic wheezing, that is expiratory and then inspiratory wheezing. Typically, these kids have a prolonged inspiratory to expiratory ratio because of the prolongation of the expiratory phase. With more severe disease, airway obstruction may be severe, and you'll hear a significant decrease in breath sounds. This would be associated with dyspnea and increased work of breathing, accessory muscle use, and certainly the inability to do any sort of activity, exercise intolerance. Keep in mind a sole presentation of asthma, which is called exercise-induced asthma, can certainly occur. And for the most part, this means that in all other cases, the child does pretty well. Unless they start exercising after a certain point, they will then have the symptoms of asthma, again, primarily expiratory wheezing, which is diffuse and symmetric. Asthma in children now is a clinical diagnosis. We typically don't resort to tests like a methacholine challenge test. You can certainly, if the diagnosis is in question, do a challenge test in that you can have the child run around, do some exercise, see if it brings on the symptoms, and then give a breathing treatment with a short-acting beta agonist, whereupon we should see the reversal of the symptoms. In addition to that, in older children, that is typically greater than about 5 to 6, who can be taught in a relatively short period of time to blow appropriately into an office spirometry. The gold standard then is the spirometric finding, where upon evaluation of the flow volume loops which are produced, we get the value of the forced expiratory volume in 1 second compared to or divided by the forced vital capacity. And in children with asthma, in children then who have perhaps exercised and brought on some bronchoconstriction, then we'll find that that value is decreased below the good level of about 85%, 0.85. So we might have values at most then down to 0.8, and with more severe airway obstruction, it would get less and less and less. Now, once again, if you do this, and you do this in the conjunction of symptoms which were either spontaneously occurred or brought on perhaps with exercise provocation, then giving the bronchodilator should again show a clinical improvement, and testing the FEV1 once again and comparing it to what we just saw during the acute attack should show at least an element of significant improvement. So we have a very objective finding then that we can apply in those children who are able to blow into an office spirometry to produce good flow volume loops. Again, children under 5 years of age consistently cannot do this, and so there's no point in even doing it. We generally try about 5 to 6 years of age. Now, once we have made the diagnosis of asthma on a clinical basis, a lot of education is required for the child and the family, and this generally takes weeks to months to ultimately get through and for the family to master as time goes on. We want to provide them with one of the many different types of peak expiratory flow meters that are available, because this is the best home tool to use to monitor the lung function, particularly in cases when the child starts to get sick. All the child has to do is take a deep breath and blow into the end of this. And typically when we have made the diagnosis, we ask them over the next few weeks to do this a couple of times a day, to write down the values of leader flow, which is produced by a little ball in the middle as they blow, and to write those values down and come back with them so that then we can establish the personal best. That is, during a period of doing well, the highest peak flow that the child can achieve. And we can use that going further, and the child and the family can use that as a comparative point going further, so that when they become ill, when they start having symptoms, and as their airway function deteriorates, if their peak flow, the best that they can do, gets down further and further and further away from their personal best, then indeed they're getting sicker and sicker and sicker. And if it's significant, they may need to be seen immediately in an emergency room without waiting for anything whatsoever. The American Academy of Pediatrics says that at least during acute asthma attacks, we should not use radiology routinely. We should only get a chest x-ray if we think that there's something else that we're going to diagnose. But often with the diagnosis of asthma initially, just as a baseline, particularly when the child is doing well, to have something later to compare it to in case we do feel there's a specific reason to get an x-ray, then we would find the typical findings, perhaps, of a child with asthma because of airway obstruction, and this is hyperinflation, some flattening of the diaphragm, and parabronchial thickening. The parabronchial thickening is entirely nonspecific. Again, keep in mind that children with mild asthma may not even on the baseline x-rays have any of these findings, and during the time of an acute attack they may not have any new findings. So when would you get an x-ray in a child with an asthma attack? Well, if perhaps you think that it was precipitated by a spontaneous pneumothorax based on your clinical exam, or perhaps a pneumonia, in which case, yes, we would go ahead and get an x-ray for those purposes. The overall treatment of asthma is based on asthma severity, and all we have to do is divide it in between intermittent asthma and persistent asthma. It's a little more complicated than this, in that persistent asthma then has a mild to moderate to severe category with increasing severity and amount of symptoms, frequency of symptoms, and the need for medications. But we don't need to worry about that, not for this test. So children with intermittent asthma have symptoms at most 2 nights per month. That is 2 nighttime awakenings per month on 2 different nights, and no more than 2 individual days of symptoms in any week. If this is the case, then this is intermittent asthma. They have no need for a daily controller and maintenance medication, and all they need to do then is, when they infrequently have symptoms of asthma, is to start their short-acting beta agonist. If the child is old enough and skilled in the use of a meter-dose inhaler, this can be used. Younger children can use a meter-dose inhaler in conjunction with a spacer or an aero chamber and a mask to deliver the drug more easily. And the very young children in the acute situation, the acute emergency treatment of asthma, we can use a nebulizer. Now, anything more than this, meaning more than 2 individual days in any 1 week, and more than 2 individual nighttime awakenings in any 1 month, constitutes persistent asthma. And the only reason then to bring up this delineation between the two is that all persistent asthma, that is any more than the intermittent asthma, now needs a daily controller and a daily maintenance medication, and the initial drug of choice is going to be a low-dose inhaled corticosteroid. So the most important of the quick relief medications are the short-acting beta agonists, and in the United States, and in children, we primarily use albuterol and levoalbuterol. The levoalbuterol is the isomer, and it is more effective, faster onset, less side effect than the albuterol. The problem is that levoalbuterol can only be given nebulized, and so perhaps can be used in very young children who can only use a nebulizer, and it's used most commonly then in the acute exacerbation of asthma. So it is the drug of choice for rescue of an asthma attack, irrespective of whether the child has intermittent or persistent asthma, and it is now the drug of choice to prevent exercise-induced asthma. So what we do, for instance, is tell the family for the child who is exercising, playing a sport, to take a puff or 2 of the short-acting beta agonist about 20 minutes prior to the onset of the exercise, and then maybe they might have to redose themselves 1 more time after some time goes on, depending on how they feel. Sometimes the short-acting beta agonist is not that effective, and the child might find that with exercise they're using a number of doses. in which case we have two choices if the exercise is going to continue. And that is, under this circumstance, cromolyn can be used instead, or the patient can be put on a daily inhaled corticosteroid. The second of the acute treatment drugs is the anticholinergic group, and the one that is FDA approved for use in children in the United States is ipratropium bromide. It's significantly less potent, and in children it typically is not used the way that it is in adults. For instance, in adults we have a brand name called Combivent, which is the combination of albuterol and ipratropium, and that can be used in a metered dose inhaler. Because of side effects, that's not done in children, and so we'll see that ipratropium bromide is primarily used in the emergency and hospital situation where it's added to albuterol or levoalbuterol for acute asthmatic attacks. And the third is going to be a short course systemic glucocorticoids. Now, not inhaled. Inhaled corticosteroids is a maintenance medication. Systemic means oral or IV. So on an outpatient basis, we will typically give prednisone in a short course with a severe flare-up. That will be defined as 3 to 7 days. And if the patient needs to be hospitalized, they may start with IV steroids, for instance, IV methylprednisolone. And as they're breathing easier, as their oral intake is able to start and increase, then they can be switched prior to discharge to prednisone to continue the prednisone on an outpatient basis, again for a total typically of about 3 to 7 days for an acute attack. These are the most important maintenance or long-term controller medications in children with asthma. Again, the most important are the inhaled corticosteroids. There's actually 6 FDA approved in the United States. 3 examples are given here: budesonide, fluticasone, mometasone. And again, they are the first drug of choice in starting in low dose for persistent asthma. We always want to step up therapy to get control of the symptoms for children with persistent asthma. And that means if we start with an inhaled corticosteroids, one of the options that we have is to gradually increase the dose of the steroid until we find that it is effective, perhaps in controlling the symptoms. The next group is the long-acting beta agonists, and the one that is FDA approved in all children of all ages, that is at least down to 1 year of age, is salmeterol. This, remember, because it's a long-acting beta agonist, is not a rescue drug. There's no longer any monotherapy with salmeterol. It is always packaged and combined together and sold in conjunction with an inhaled corticosteroid. So a very common drug that is used in children and adults is the brand name Advair, which is the combination of salmeterol and fluticasone. Long-acting beta agonists, particularly by themselves, without the addition of an anti-inflammatory, has in the past been found to increase sudden death. And so we use these if we have to, as an add-on medication, as I said, to the inhaled corticosteroid. But if we don't have to use it for long periods of time, that is, if we try to get off the drug and the child then does well, once again with either an inhaled corticosteroid or perhaps with another add-on drug, then we will do so because of the increased risk of side effect, primarily the relatively small increased side effect when it is combined with an inhaled corticosteroid of sudden death. But we certainly have to explain that to the parents and give them the option of perhaps not using this. So another option then to get control, to step up therapy, besides increasing the dose of inhaled corticosteroid, is simply add on the long-acting beta agonist to the dose of inhaled corticosteroid that you were using. The next add-on are the leukotriene modifying agents. And in the United States, we primarily deal in most children with receptor antagonists. And that's going to be montelukast and zafirlukast. Zafirlukast is used in slightly older children. Montelukast we can use in very young children as well. These are oral medications in different doses, are quite easily given, and once again is an add-on to an inhaled corticosteroid for the best effect. And that means you have your choice. You can start with an inhaled corticosteroid, and when stepping up on therapy, you can do an add-on with either the long-acting beta agonist salmeterol or the add-on with the leukotriene receptor antagonist, either montelukast in younger children, or if you want, zafirlukast in older children. In the United States, we only have one FDA-approved inhibitor of leukotriene synthesis for children, and that is Xylutin, and it's only used in adolescents. That is, you have to be at least 12 years of age or older. In severe cases, then, systemic steroids are used, meaning daily prednisone, and this would be a child then typically with severe persistent asthma who's on the highest dose of an inhaled corticosteroid plus an add-on medication. And typically what we would have found would be the add-on medication that worked the best after trying both of them. So high-dose inhaled corticosteroid with either salmeterol or with one of the leukotriene modifying agents. If those are not successful in controlling the symptoms, then daily prednisone to start with usually is going to be. Now, of course, that's going to lead to significant side effects, that is Cushing's syndrome. And so what we will try to do when we get control of the symptoms is first decrease the dosing of the steroid to as low as possible. We may, for instance, start with trying to go to alternate day, every other day prednisone therapy, and then decrease the dose as low as possible until we get control. Theophylline is rarely used anymore compared to years ago when it was the drug in the treatment of asthma. The problem is that it is given orally and has a very narrow therapeutic window, and so we have to get levels because outside of the level it has a lot of side effects associated with it. And it simply isn't as effective as the other drugs that we've been talking about. So it's uncommonly used. It's usually used then in the severe cases as a final add-on drug, perhaps before going to prednisone or in addition to prednisone to try then to decrease the prednisone dose as low as possible. It is currently felt that there is no primary use of the chromoglycolates, that is cromolyn sodium, in childhood asthma anymore. It's an alternative use, particularly in very young children with persistent asthma, where the physician may not want to start on a corticosteroid, in which case there is a protocol for the alternative use of cromolyn, and rarely in other conditions. But again, most importantly for your exam, remember, no primary use, almost not used anymore, and for all intents and purposes, we can say that this is an answer you're not going to choose on your test for children with asthma. This is the basis for the protocol of dealing with emergent management of asthma exacerbations. As usual in the emergency room, and not listed here, the first thing that we always have to be concerned about, with anybody for that matter, with any acute respiratory problem, are the ABCs of resuscitation. That is, establish an airway if necessary, make sure the patient is breathing spontaneously or we are breathing for the patient with ventilation, bag and mask or ventilation, and the patient is well perfused with good pulses and blood pressure. That is, the cardiovascular system is intact. Assuming that this is taken care of, then the first most important step in management is the placement of a pulse oximetry. And almost always with acute severe exacerbations of asthma, these children are going to have some arterial hypoxemia, and that means that typically the pulse oximetry in room air is going to show saturations under 92%, which means the vast majority of them will need some oxygen, and then we'll monitor that with the pulse oximetry. The basis of the treatment is twofold. First, to give a corticosteroid as soon as possible, and it can be given orally or IV. If the patient doesn't need an IV for any reason, they're not dehydrated, you're not concerned about their breathing to the point that you're afraid to give them an oral corticosteroid, then you don't simply need to place an IV for this. They can be given oral prednisone. Absorption and onset of working of the drug is not significantly different between the two methods, studies have shown. In conjunction with that, then, we will start breathing treatments, and this is involving an inhaled short-acting beta agonist. It can be albuterol or levoalbuterol, and we give a maximum of 3 doses, about 20 minutes apart, and therefore it takes about an hour or so. So you evaluate the child beforehand, you give the dose, and you evaluate them afterwards. Not only with respect to wheezing, because usually by the end of the protocol the child's still going to have some wheezing, but you're concerned about the other major things that will determine whether the child needs to be hospitalized or eventually be able to go home. That is the quality of the breath sounds, how good air movement is, whether or not there is accessory muscle use and increased work of breathing, and whether or not the child maintains on oxygen or not, or can be weaned to room air. So again, we have 3 chances, 3 breathing treatments. If the first one, which is just albuterol or levoalbuterol by itself, does not result in improvement with respect to those things that I said, again, the child weaning off oxygen, has no more findings of respiratory distress, and has good air movement, then we need to give a second breathing treatment. And the standard of care at this point, since we now need a second one, is to let's do a little more to try and get the patient home as opposed to having to admit him to the hospital. So we will then add the anticholinergic ipratropium to the short-acting beta agonist. Now, when we do this, when we combine a beta agonist with an anticholinergic, that means the side effects are going to go up tremendously. The cardiovascular side effects. Expect tachycardia and jitteriness and sweating, and this can't be helped, but the child has to be carefully monitored at this point. Now, we will only use the ipratropium once because you cannot give it again for another 6 hours based on side effects, based on its pharmacokinetics. After we've done this, then go back and evaluate the child. If the criteria are met that I have talked about a couple of times now, then the child can go into the discharge arm and be evaluated for possible discharge. On the other hand, if the criteria are not met, then the child needs the third and final breathing treatment, which again is back to either albuterol or levoalbuterol. And then the child is evaluated again for the same findings. If he is significantly improved off oxygen, has no increased work of breathing, and is moving air well, he can go into the discharge arm. And again, if those conditions are not met, that's the indication for hospitalization. So when he gets to the discharge arm, anytime along this time, we need to watch him for 4 hours. He's allowed to have another breathing treatment or so, or two during that period of time for wheezing, but he can't be worse again at the end of that 4 hours. He can't go back onto oxygen. He can't have respiratory distress again. His breath sounds cannot get worse. So he can go home if he has sustained improvement with normal physical findings, oxygen saturations greater than 92% after 4 hours in room air. And if it's a known asthmatic, and that asthmatic has done peak expiratory flow meter testing, then the child needs to have a peak expiratory flow meter test done, and the value of that has to be at least 70% of that child's personal best. The child is then discharged on breathing treatments of some form, either a meter dose inhaler or a nebulizer, typically every 3 to 4 hours around the clock, with close follow-up, perhaps the next morning, by the primary care physician, and as I said previously, a short course, 3 to 7 days, of oral steroids, and this is not weaned. It's the same dose at the beginning as it is in the end. We do not taper it any longer. The reason that we used to taper it was simply because we were worried about the symptoms coming back if we didn't tape. Studies, however, show that it was the tapering of the steroids over this short period of time that actually led to a resurgence of the symptoms again, and now we aren't seeing that as much when we keep the steroid dose exactly the same. You don't have to worry about interruption of the pituitary adrenal axis in the doses that we use for this short of period of time. That's simply not going to happen. Note in this protocol that there was no x-ray. Remember, no routine x-ray unless you have a darn good reason to get an x-ray. And we certainly, in this typical case of the way the vast majority of children present with an emergency asthmatic attack, do not need an arterial blood gas for any reason. So as I said, if the protocol fails after 3 breathing treatments, which takes about an hour, sometimes a little longer, that is, for moderate severe flare-ups without improvement within an hour or so, and with the initial acute therapy showing us then peak expiratory flow less than 70% of the personal best in a known asthmatic, and or the inability to keep oxygen saturations in room air greater than 90%, then the child needs to be hospitalized. And when they are, they're all going to need oxygen. They may or may not be able to eat, depending on how fast and how severely they're breathing, that is, how much respiratory distress they have. If they can't eat or drink, then of course they need IV fluids as well. Therapy, again, is going to be pretty much the same as on an outpatient basis. Breathing treatments with albuterol, and then albuterol plus ipratropium, as long as the ipratropium is given no closer than every 6 hours. IV corticosteroids if the patient can only have IV fluids. Otherwise, again, just like on an outpatient basis, oral prednisone can be given. If IV corticosteroids are started with, at some point with improvement, the patient can be switched over to oral prednisone, and then this continues for the total of 3 to 7 days of short course of corticosteroids while the patient's being discharged home. As I said, he may or may not need IV fluids, and if the patient is so ill that there is severe respiratory distress, that oxygen requirements typically are high, breath sounds are poor, and the child is so breathless that they're basically have the inability to speak, then these types of findings, the most severe patient needs to be taken to the intensive care unit as soon as possible. And now, in conjunction with those types of findings, and certainly with admission to the ICU, that child needs an arterial blood gas to determine whether or not he's in respiratory failure, and if so, has the strong possibility of having a respiratory arrest, completely obstructing his airways. If this is the case, the blood gases then, in conjunction with the appearance of the child would indicate the need for immediate mechanical ventilation or perhaps mechanical ventilation in a while. If the intensivist decides that based on the blood gas then that the child does not need immediate intubation and ventilation, but it can wait, then a number of other ICU therapies, which we don't need to discuss, can be done to try and keep the patient off a ventilator. These would have to be done, however, because even if he didn't need to be intubated right at this moment, the strong possibility of the child continuing to breathe with the rate and depth of breathing that he's breathing at because he's so sick means that in time, and it might not be a very long time, he could tire out, which means that his oxygenation is going to get worse yet, and he will become significantly hypercarbic and acidotic, which means at that point he would need to be intubated. So we do everything we can in children with asthma, and in children with obstructive lung disease, and anybody for that matter with obstructive disease, to try and keep them off the ventilator because they are difficult to ventilate because of unequal ventilation, and it's very difficult sometimes to get them off a ventilator. And so the principle will be, once again, all the therapy that is necessary to keep the patient off a ventilator, but if blood gases show that that is not possible, then of course the patient needs to be intubated and ventilated immediately.